hero is someone who helps everyone reach their objectives. That's why we call ourselves the Tooth Heroes. If you focus on being a tooth hero, you will be successful. There's several components of dentistry. All of you guys have the components of dentistry, with the exception of business. This is why we're here, to support you in all of those business components. That being said, the components that we will focus on in other meetings that we have in this space, we're going to talk about the economics, the finance, the marketing. I think, is DePasquale here? Is he in the room? I can't see him.
I think he's in the back.
Okay.
Fighting more risk.
He's a financial planner and someone that Marcus really looks to and expands and supports him in everything that he does. But whether it's marketing, which is our next month topic, management, technology, law, or social responsibility, these are all things that we talk about. There are only 5 reasons people connect: family, religion, money, health, sex. We love entertaining the P's. We love our sponsors. Beth from Voco is one of our sponsors. So Beth, would you please talk very quickly about the products and your thing, and then we'll pass it over to
Thanks.
To Marcus.
I'm Beth. I work closely with George. I'm the rep for Voco in New York City, the Bronx, and Queens. And if it's the first time you're hearing the name Voco, it's not the first time I've heard that. It's a 32-year-old company, family-owned company. Everything is made in Cuxhaven, Germany, from our packaging to the actual product. Something else. In your kits back here, there's some things I included. Our bonding system. It's a universal bonding system called Futurabond U. Without getting into it too much, basically, it's a universal bond. So you can etch with it, you can use it as a self-etch. It's really quick and easy. The instructions for use and our catalog and everything is in there too, just so you don't remember anything I'm saying. Some products that you would probably love.
Cards in there too, so if there are any questions,
yeah, you can text me and call me. Our caramel fluoride varnish is so popular. It smells great. You're shaking your head, yes. You can smell it, try it, use it on a patient, see how you like it. Again, call me with any questions. What else do we put in there? Some of our composite. We have some of the highest filled composites on the market, so there's less resin in them. They don't shrink, stain, wear as much. Very popular too, called Grandioso. So all that's in there, but my goal is just to meet all of you guys and hope that you'll try some of the products and expand. We've been in the US about 13 years, so again, if you haven't heard the name, we're a little bit smaller than some of the other companies.
And we thank you for the barbecue.
Yeah, you're welcome.
Yeah. Marcus has just come back from key opinion leader training at Colteen, but Dr. Lori has insisted on putting this topic together to expand and create questions. And with that, I'm going to let Marcus do a thing now.
Cool.
Two times. Nonetheless, I appreciate it. Very excited. Thank you so much for showing up. I have to extend a sincere hand of gratitude. I really just thought it was going to be myself and Dr. Hyacinth here just discussing the whole pedo-endo sort of issue. My name is Marcus Johson. I am an endodontist in private practice here in Manhattan off of 30th, 40th Street in between Park and Madison. Just opened up about a year ago. And then I also associate with my mentor, Dr. Al Granger, in Long Island. I really pride myself on practicing evidence-based endodontics. So I'm going to go through some slides with you, talk about a few issues that are very important to me, but hopefully you'll be able to take some key pearls of information away from it and learn and apply it to your own practice. But any and everything that I discuss, there is some literature to back up why I use it, why we're discussing this, because I think the literature is so valuable. We are dentists, we are scientists, and it's important for us to really know the basis of why we treat, couple that with empirical data, and then deliver the best treatment for our patients. Okay. So yes, welcome to the lecture, Regenerative Endodontic Procedures, a new protocol in the management of open or immature apices. Now it sounds a little bit probably more convoluted than it actually is. It sounds extremely scientific, but once we get into it, you'll see that it's pretty basic. And really, it's just a nice way that I'm able to frame a few techniques that have been introduced into the endodontic literature that you can go ahead and take and adapt to your own practice, in residency or what have you, and then apply that on your patients and hopefully have some successful cases. Of course, I would be remiss if I were not to thank Dr. Carrie Cunningham for just allowing us to use this space right here. So hands up. Thank you so much. And a lot of you are just, maybe finishing up. We're looking to finish up within the next year. Please, enjoy some conversation with him. This is a beautiful space. It's very nice. It's quaint. And it's a trendy neighborhood. It's up and coming. So we're looking for new people to come down to this region and start practicing. Goals and overviews. We really can't discuss this topic without understanding the basis of why we do what we do. So we're going to get into a little bit of microbiology, look at some literature on medicaments and irrigants. In addition, review some traditional treatment methods used to manage open Apices, probably a lot of them that you may be familiar with. And then, of course, we'll get to sort of the hallmark of this presentation and highlight that new treatment protocol for regenerative endodontic procedures. Just to poll the crowd, can you guys tell me, mainly the Pete Dawson, what are you guys doing when you see these cases of, immature apex? Someone comes in, they have a tooth trauma. What are you guys doing when you see these cases? Are you familiar with the literature? Are you comfortable managing these type of issues? Just like, what is your initial sort of response? And I forgot to mention, please, I don't want you to think that I'm lecturing to you guys. I want this to be an open discussion. Like I was kind of joking when I said I thought it was going to be me and Dr. Eisen. I really wanted this to be a general conversation. 2 years ago, I was in your shoes, just listening in on lectures, trying to learn as much as I can. I still learn when I'm up here talking, so ask me questions. Let's just engage in dialogue. So at the end of the day, we want to be the best clinicians as possible. No need to settle for mediocrity. Let's excel. So please feel free. Okay, so I'm assuming.
I'm familiar with the procedure, but I personally haven't treated a patient like that. I go on dental trauma guys after.
Yeah, with Andreasen, right? Andreasen, he's phenomenal. Anytime you need any sort of guideline how to treat someone who has a fracture, what have you, that's the source. But what I'm saying is, what are you guys doing if you see a case of an immature apex, like a child comes in, 9-year-old, open apex? What are you doing? What type of procedures do you normally do?
We have to monitor it, but then ideally, in the residency we talked about, we're set up to do that with the triple antibiotic phase and
right, exactly.
Revascularization followed by MTA.
Good.
Ideally, we want to follow up vitality and give it a shot, because a lot of times that initial trauma will not respond to thermal testing shortly after the trauma.
Okay, so I just want to get an idea. So it's nice to know that you guys are even familiar with what I'm going to be discussing. Okay. So regenerative endodontic procedures. Okay. What is the basic, goal of this new protocol? Essentially, we just want to regenerate functional pulpal tissue utilizing various treatment protocols. I wanted to stress treatment protocols because what we're saying is that the literature is still in its infant stages. So we're getting a lot of literature, a lot of sort of case studies from different practitioners, not really high-level evidence studies. And we're just kind of adding this to a database, and we're saying, here's kind of the guideline, and then apply where it's necessary. And then we're seeing some successful cases, some cases that are not that successful, but it's ever evolving. So that's why we always want to stress treatment protocols. Regenerative endodontic procedures is going to encompass pulp revascularization. This term kind of stems from the dental trauma literature. You mentioned Andreasen earlier. Okay, right. And so when we think about revascularization, we're thinking about maybe some sort of avulsion case. And what happens when you have an avulsion is the tooth is obviously knocked out the socket. We have to go ahead and reinsert it. But what you're relying on is that native tissue that's already present within the canal to sort of regain that blood supply, either through angiogenesis or some sort of anastomosis process. Okay, so that's just at the basic level for revascularization. There's been some confusion in the literature versus revasc and regeneration. It's a big difference because when we talk about revasc, like I said, we already understand there's tissue, vital tissue, or some sort of native tissue that's already present. The phenomenon of pulp regeneration is that we're dealing with a case that is necrotic. There's infection, inflammation, okay? And now we take that and we're able to sort of bring together a new life, a new tissue, so to speak, within the canal space. So you're dealing with a tooth that has undergone maybe some sort of liquefractive necrosis, and now, after initiating these sort of procedures, you now have a tooth that not only responds vital, increased apical wall dentin, apical thickness, and increased apical development. Okay. And the way that it occurs more or less is through tissue engineering, and then we couple that with regenerative medicine. Okay, so we're going to be discussing a little bit later stem cells, scaffolds, and growth factors, and how all of these sort of repopulate the canal space, and then we end up with a regenerative endodontic procedure case that is successful. Bonches and Trope, 2004, JOE, Journal of Endodontics. Is anyone familiar with this study? Okay. Classic literature. This is a classic study.
Knocking at the doorbell.
Okay, this is classic literature, and the hallmark of this study is that Bonches and Trope, they're great endodontists. They're actually well renowned. They had been kind of following the Japanese literature, okay, and they had seen cases where they were noting that we can maybe apply some sort of special medicament within the canal. The tooth that was previously necrosed now is actually showing some signs of vitality, this and that. So they said, well, why don't we see what we can do? Let's apply it here in the States and see what happens. Okay. So this was the case that presented. You have a 11-year-old child came to the clinic, and this is what you see. When you see this, what does everyone think? Probably you're saying, oh man, this is hopeless. Saca la muela, right? Take it in. But in actuality, they said, no, we see that this is a potential to bring something back to life, okay? So, diagnosis, necrotic pulp, chronic apical abscess. I'll get into diagnosis a little bit later, but it's important that you guys understand that in about 2004, the American Association of Endodontists, we kind of came together and collectively said we need a new sort of diagnosis format so that we can speak in a collective language and understand one another across the basis. So it's kind of standardized. So this is the new diagnosis. No more chronic, what was it before? I don't remember, to be honest. What is it? Just for the residents, we said use a different semantic system. But necrotic pulp, chronic apical abscess. Obviously, we can see that it is necrosed because this is a sinus tract which traces right to the apex. You have the gutta percha tracing right there. You can see just all the lesion. It extends all the way up to the cervical region down here in the apex. Most people would extract this too, okay? So what did they do? They went ahead and initiated some regenerative endodontic procedures, and now you can see in a 2-year follow-up, we have increased apical development, dental wall thickness, but the kicker is that now the tooth, which was once necrotic, no response to endo-ice, now is biting. That's pretty amazing, right? So we're going to discuss how that occurs, but I just want you guys to have a picture to sort of associate what we're going to be getting into a little bit later. But of course, before we can get to that point, we have to understand what we're dealing with and what are the best ways to go ahead and eradicate that. So just to poll the crowd, what is the etiologic agent in any sort of endodontic infection? Don't be shy. It's not hard. Remember, I'm just a regular resident like you. We're just having a good conversation. Excuse me?
That's bacterial name?
Yeah, it's bacteria. Microbes, right? The etiologic. What is it?
I just said I said it, Martha.
Oh, okay. But I should probably know. This is my mother. Beautiful smile you see back there. That's my mother. Just a side note. Whenever I treat patients, I always lead with, okay, you're in great hands. Please don't worry. I'm very good at what I do. And I will treat you as if you were my own mother, who I love dearly. Okay. So you have to put that in there because sometimes people don't love their mom. The funny thing is, she flew 3,000 miles from Denver, Colorado, my hometown, and I actually did a root canal on her today. So
and I'm
there's
alive
a
and
lot
well.
there's a lot of truth to that now. So when I say it to my patients, there's a lot of truth because I actually just did a root canal and everything worked out well. So God's good.
Yes.
But yeah, it's bacteria. Okay. Again, classic endodontic literature. Takahashi, Stanley, and Fitzgerald in 1965, they said, we kind of have an idea that bacteria is the problem, but as we all know, you have to actually have some sort of data to substantiate this, right? So what did they do? They took two populations of mice. They had a notobiotic population and a conventional population. So everyone familiar with the term notobiotic?
Germ-free?
Germ-free, thank you. I like this guy. What we're going to do is we're going to do a co-lecture. Yes, so they were bred and raised in sterility, right? Then they went ahead and created pulpal exposures in these teeth, and then they observed for 28 days. And what did they find? In the notobiotic population, you saw dental bridge formation, and you saw vitality retained. Conventional population, guess what happened? You saw advanced decay, you saw abscess formation, So all the problems associated with endodontic infections. So from this study, we surmised that in the absence of bacteria, vitality will still be maintained. So the etiologic agent is bacteria and microbes. This was back in '65, so more or less all endodontic literature we kind of base upon this, okay? So microbes and endodontics, we understand we're dealing with polymicrobial endodontic infections. Again, we talked about different bacteria. Now, sometimes when we do root canals, we're going to do it in 2 visits as opposed to 1. Nowadays, with all the contemporary endodontics, vials, irrigation, things of this nature, we can have successful cases in 2 visits and 1, and there's no significant difference. However, you still cannot neglect that sometimes you still may need to apply an antimicrobial sort of medicament in between. Okay. And apical periodontitis fits acceptable criteria for classification as a biofilm-induced disease. Biofilm was an extremely hot topic in endodontics from, I guess, the past 6 years. It still is a hot topic, but now we're kind of moving away to cone beam technology and focusing on that. But everyone here is familiar with biofilms and why it's such a challenge to actually get in there and eradicate this bacteria. Because this is what you're up against. It's not just bacteria in a planktonic, free-floating state. No, we're dealing with bacteria that are sort of have a symbiotic relationship. They're feeding off one another, they're helping one another. They have mechanisms that are going to say, you know what, if this one dies, but this one actually aids it by helping it to block some sort of attack. Bottom line is, when we deal with a biofilm, we understand that you're going to need at least a 10-fold to 100-fold increase in whatever antibiotic you're using, whatever medicament or irrigant you're using to break this up. So when you understand what we're really dealing with, the infection, there's no reason why anyone should not use a rubber dam on any and all cases, right? There's no reason that you should try to maintain aseptic technique at all times. Because you want to be the best, you want to provide the best for your patients, so why not start off with the basics and do it right, right? Necrotic pulp tissue becomes a favorable environment for microbial proliferation. This schematic just is an illustration showing us that all up and down the canal we're going to have a lot of bacteria, but specifically down in this apical region, we can see there's sort of a separation down in here. Bacteria can penetrate these regions down here, get in the dental tubules, and populate these areas. So the goal is, how do we get down this canal, but how do we clean out this apical delta and be effective and have successful cases? Okay. We know that as we progress down, we're going to get more facultative strict anaerobes, some facultative anaerobes, but we understand that we're dealing with bacteria that more or less live in the presence of little to no oxygen. So we want to get in there, reach and change that redox potential, therefore giving us a better chance to kill that bacteria and have a successful case. So I don't want to hit you guys over the head too much with the microbiome, but I just want you really to understand that it's so important to understand what you're really up against, because then you'll really understand what's the proper treatment to get the most successful cases. E. faecalis was very popular within the endodontic literature as well, specifically because it does have a biofilm. It has an affinity to have a biofilm formation. Sprat. No relation to you, right, Brad? No, but it forms a biofilm very easily, so it's good in the laboratory. You can run a lot of studies on to see how it actually is going to respond in the tooth and what have you. But what's really special about this is that it is resistant to calcium hydroxide. I'm sure most of you guys use calcium hydroxide probably on at least a weekly basis, if not daily, right? And the mechanism by which it works is it has a high alkalinity. So it's that very basic sort of nature that's going to disrupt the cell membrane and lead to lysis. A lot of people have a misconception that it's actually, it functions as an antibiotic, but actually it doesn't. It kills along some of the same mechanisms, but it's the high alkalinity, this pH, that really allows it to be effective. And what's interesting is when you are faced with an E. faecalis biofilm, you actually try to break up this biofilm with calcium hydroxide. You're not too successful because it has a proton pump, which is going to kind of counter that high alkalinity environment. Okay, so we oftentimes see that E. faecalis is very prevalent in refractory cases such as retreatment and things of this nature. Okay, so just giving you an idea that it's not just one bacteria we're dealing with, it's polymicrobial. It's a big challenge, so you have to have a lot of different things in place to go for a successful case. So, ideal irrigant properties. Let's go ahead and get into that. Can someone just give me maybe one property you would want in your irrigation, your irrigants? Okay, I like that. Yes, must be antimicrobial. That's, you can't have anything that's not. I mean, just throw anything out. We're just having a discussion.
Chelating agent.
Anything?
Chelating agent?
Chelating, yeah, that comes up a little later, but hey, we got to link up. Of course, it has to have tissue dissolution, okay? Non-toxic, carcinogenic, you don't want it to be carcinogenic. Lubrication, we understand that when you go into a canal with lubrication, you increase cutting efficiency by about 300 times. Hugo Henry. Not just knowing that she's a female researcher, but her name is Hugo-Henry, so that's just a lot of women are doing that, keeping their name and taking their husband's last name after the hyphen. But she did that study, and she showed that lubrication is valuable. There's a lot of values there. Easy application. You don't want something that's so hard to apply, you know, you have a headache trying to just use it. Inexpensive. Dentistry today has changed. I've been in practice in Manhattan for a year now, and it is a big challenge from a specialist standpoint. So you want to keep costs as minimal as possible, so that's definitely something you have. Substantivity. I know you already know what this is, right? But can someone else tell me what substantivity is? Essentially, when you place the medicament within the canal, you take it out, it's still going to have its effect, even after it's gone. So you need something that's going to have residual effects because you want to, again, kill off all bacteria. Inert, you don't want it to really react with the dentin and things of that nature. Penetrate dentin tubules, remove smear layer. This is what he's talking about when he said the chelator. Okay, it's kind of chelator. Bind calcium and actually get in there and penetrate those tubules. So the best thing that we have nowadays is sodium hypochlorite. I put the 6% because if you ask any practicing endodontist, what percentage of hypochlorite do they use? And they say, oh, you know, I use 0.5%, or 2.5. You may want to consider sending those cases to me. No, but in all seriousness, we always advocate 6% hypochlorite because we understand that when you have this, you're going to have the best chance to kill off the most bacteria. Not too many things can survive in the presence of full strength bleach. Okay. And in addition, it has tissue dissolution properties. There's a discrepancy. Sometimes they say it's 0.5%, 2%. Bottom line is when you have full strength hypochlorite, you don't have to worry about tissue dissolution because it's just going to happen. Now the concern with hypochlorite obviously is it's cytotoxic to tissues, right? And you don't want to be the dentist who had this happen to. Okay. This is a hypochlorite accident. It is real. It does occur. I've had some happen, not to this degree, but the patient may say, you know what, doc, my tooth is hurting for some reason. I thought I was numb. And you say, you know what, let's take a step back and really evaluate and see what's going on. So the thing is, you don't want to practice scared, but you should practice aware. So understand that this can happen, and that's why we don't like bleach, but if you practice well within the standard of care, it really shouldn't be a concern. But God forbid if it does, what you do, you just want to rinse out the tooth with copious amounts of water, okay? Reassure the patient, stay calm, be confident, you are the doctor. The patient is going to look to you for comfort, for reassurance. You don't want to lose your head, okay? Secondly, you're going to want some antibiotics, obviously some extreme pain medication, and worst come to worst, you may have to refer them to a hospital. They may need IV antibiotics. Okay, they will rebound, they will be resilient, but they're going to have some days where they kind of look like Quasimodo. But at the end of the day, I'm just being honest. I mean, it's not a laughing matter, but you know, she's a lovely lady. This is just a disfigurement, but you should see her before and after. She's fine. Decreasing concentration reduces toxicity. Yes, so that's a good thing, but then you lose the antimicrobial effect and the tissue dissolution. Okay. Johson, that's not me, it's actually another Johson I know. But increasing the volume or warming it is something else you can use when you want to use your hypochlorite. Chlorhexidine. Any of you guys use chlorhexidine? Yeah. And why do you use it? Antimicrobial? Yeah, antibacterial. It is. It's a good antimicrobial irritant. Okay, specifically, we want to target E. faecalis, which we know has resistance to calcium hydroxide. This is where we call on chlorhexidine. Good stuff. Make sure you always have 2%. Don't use the Paradex. It's not as effective. Get the 2%. It's good. Okay. The problem is there's no tissue dissolution. So if you're trying to use it as a substitute for your hypochlorite, that's okay, but you're really not doing yourself any justice or due diligence because there is no tissue dissolution. So all that necrotic tissue, any vital tissue is remaining, still has the potential to lead to infection. And it cannot remove smear layers, so we have to rely on things like this, EDTA. You guys are all familiar with EDTA? Right. 17% chelating agent. It's going to bind the calcium. It's going to go ahead and open up those dental tubules. You have to use this stuff after you use your hypochlorite, and then you can use it in between before you use chlorhexidine, because there is a precipitate that forms if you use chlorhexidine right after hypochlorite. And then once you form that precipitate, you can't actually get it out. So make sure you always irrigate in between with this if you're going to use all three irrigants. And that's what you should do, but just make sure you do. So this is just a little schematic again, just kind of lists the characteristics and the different irrigants. And we can see there really is no ideal irrigant. So what we have to do is kind of combine them all to make our own ideal irrigant. And that's what you can do. As long as you know that, you'll be fine, but you just don't want to use one irrigation. You just don't want to use this one. You pretty much want to use all three if you want to try to achieve the best success in your cases. So we talked a lot about irrigation, and you guys might be asking yourself, well, what about instrumentation? Isn't that important? And really, that's another lecture. I really don't want to get into that right now. Instrumentation is extremely important. It's going to shape the canal. But this is another lovely study by a gentleman that was Ove Peters. He does a lot of studies on instrumentation, CBCT scan images. And what he did was he took molars that were pretty much oval in shape, distal canals. This is the pre-op. And then you can see that he has different file systems. The headstrooms, pro taper size 1, pro taper 2, and what have you. And then he went ahead and instrumented the canals. Okay. 26 days later, you're going to go ahead and irrigate with just sodium hypochlorite again. Stimulate the apical tissues. Pretty much you do this just by apical trephination. You guys ever done that? Anybody familiar with that process? Apical trephination. Get in there and just kind of put a file. You know the working length is maybe 19. Go 22. Okay, these kids, they have vital pulp tissue down, not pulp tissue, but vital tissue down in here. Stimulate that area, allow the blood clot to flow pretty much as far as you can. Go ahead, CABIT, MTA, bring the guy back 2 to 4 weeks, and restore with a bonded rhythm restoration. Okay, so that's pretty much the protocol. Like I mentioned earlier in the lecture, it varies. If you were to look at the literature, now this was back in 2010, 2009, we were doing this sort of stuff. Nowadays, other researchers are using different techniques. Bottom line is you pretty much have to have irrigation, okay, medicaments to disinfect and release the growth factors in the dentin. You have to sort of initiate some sort of bleeding from the apical region because you have to have these cells, these stem cells migrate into the pulp canal space. And you also have to have a blood clot and a hermetic seal. Okay, that 3.5 millimeters, that 4 millimeters. And then go ahead and reinforce that seal with something like a glass ionomer or what have you. Okay. So those are pretty much the 3 tenets that you must have, and we all clinicians pretty much agree that you have to have these 3 in order for it to work. Now there's a little bit of discrepancy of what medicament. Some people say, oh, we're concerned about antibiotic resistance and this and that, so we don't want to use metronidazole. Or they say, we're concerned about staining of the teeth, so let's stay away from the tetracycline family. We're not going to use metacycline. So there's different variances, but the bottom line is you have to at least disinfect the canal somehow. You have to establish bleeding, and you have to have a blood clot that flows into the canal, seal it up, and see what happens. This is very wordy. This is just a slide why we would use antibiotic and why not. Just to compare and compare and contrast. Like I said, here's one of them. Minocycline will cause tooth discoloration. I think this is pretty good. Very effective as we can have. Just to compare chart. So this right here is another study. I know you guys over here with a lot of literature, but when we're talking about something that is so young in terms of applications in the clinic, we don't have any long-term studies, so we have to base everything that we do on current literature. Okay, it hasn't been around since 1920, like calcium hydroxide. So just look at the properties. Okay, they're both antimicrobial, Broad spectrum antibiotic, yes. We already understand this works based off of alkalinity. Radiopaque, yes, but you can add a radiopaque element to it if you like. Okay. Anti-inflammatory, yes, they're both going to have anti-inflammatory properties, increase root thickness. And I put this here because usually you're not going to have that. But like I said, recently, I think it was just maybe 6 months ago, some researchers have shown that if you use calcium hydroxide, according to how they did their study, they did get increased root thickness. Now it has to be reduplicated, it has to be duplicated and tried in different sort of environments. But according to their study, and that write-up looks official, they're making these claims. Increased root length and sterile necrosis, no, but we understand calcium hydroxide does that. Okay. So this is just a chart that kind of just puts what we just discussed into diagram form. And you can see they even looked at former Cresol, and you see it really didn't have any sort of effect in root length, and had really no effect on increasing the width. The only two that we really can use are antibiotic paste and calcium hydroxide. So what are you going to do for your follow-up? How do you evaluate these cases? First and foremost, is the tooth asymptomatic? And even more importantly, is it functional, right? If the tooth is loose, if there's infection, just take it out, okay? If the patient says, I'm still having pain, you tried it, it didn't work, it's okay, take it out. Radiographic evaluation, in 6 to 12 months, you should see a resolution of an apical lucency. You may see increased dental wall thickness. And that's not always certain, but you may see this. Okay. 12 to 24 months, you should expect to see something like this. It's not always going to be a perfect sort of resolution of that apex. It's not always going to be something that's exactly like, a mature apex. But you should start to see something in here. And if you start to see lamina dura, a little PDL, I mean, you should really pat yourself on the back because that is hard to achieve. Okay. But if you do see that, you've done a great job. It's just a bit about histologic makeup. Like I said earlier, we're really not sure exactly what the tissues are that populate the canal. But some of our Japanese researchers have shown that it's a pulp-like tissue. What they did was they actually did these studies and they extracted the teeth. I don't know how they can do that, but again, this is Japan. I don't know what the standards are. No, I'm not saying it as anything bad. I'm just saying they may have different sort of regulations. And of course, animal studies, which we don't like because it's low-level evidence, but there is some sort of significance to it. And they said it was actually cementum in bone-like tissues. But the bottom line is, in a lot of these cases that have been sent to the database, we find that most of them do respond positive to cold testing when they actually happen. Okay, and this was sort of like a case review that Law did, and he looked at all the cases, not all, but a huge sample size of the cases that have been submitted. By and large, we are finding that teeth that were once necrotic, abscess formation, sinus tract drainage, you name it, if you go ahead and initiate this protocol, next thing you know, you're going to have vitality, increased dental wall thickness, increased apical development. So what is the future of these sort of procedures? I think it was in summer 2013, there was a nice article in the New York Times. That was Wall Street Journal. And they actually were talking about regenerative procedures. And they interviewed an endodontist from, I want to say it's either Baylor, it was in Texas though. And she was discussing what the future is and what we can expect. We're all very young in here, and you will in your lifetime see this sort of procedure. Tooth decay that begins with pulpitis, inflammation of the dental pulp. Next thing you know, a researcher or yourself, the clinician, will fill the canal with pulp, stem cells, and molecules to stimulate growth. So no longer are we focusing on the apicals, the stem cells of the apical papilla, but we've engineered in the lab the stem cells needed for this type of growth. Injecting that in from the coronal aspect, next thing you know, you get prompted growth, pulp cells, blood vessels, and nerves. Next thing you know, you have a regenerated tooth. There have actually already been some studies showing that this is possible, that it is reliable, that it is reproducible. But again, a lot of these things take time. You have to get the proper, government sort of patents and things of that nature to actually bring these sort of treatments to the public. But people are doing this stuff in the laboratory. Okay? And Case Western, the school that I came out of, was actually on the forefront of a lot of this research. Really good stuff. Okay, so in your lifetime, you will see that we're going to grow teeth. And as an endodontist, that may be a problem for me. But hey, God is good. I'm versatile. We'll see what happens, what other career path I may choose. But this is exciting times. I think it's great stuff. I really appreciate you guys even coming just to hear me lecture. Not really a lecture, but just engage in conversation. And just, you know, hopefully you learned something. I definitely learned from you guys as well. And keep in mind, dentistry is a profession where we can make money, so don't be shy. Try this stuff because we now have codes that you can actually submit. And so you're trying new things, but you can also get reimbursed. So it's a win-win. You're going to do a great service to the patient because you would have to do apexification procedures anyway, and if you do it correctly, it's going to take multiple visits. So why not take those same multiple visits and try a revascularization case? Document it. You're in residency. You have a lot of time on your hands in terms of working with patients. You're not like, well, maybe you are, I don't know, but hopefully you're not. So try these cases, and look, they have the codes right here. I don't know exactly the reimbursement, how much you get, but we are now acknowledging this as a viable treatment option. So go ahead and give it a try. Any questions or concerns, I'll be more than happy to serve as a resource. And I just really appreciate you guys coming out, listening, and hopefully we can get some more topics of discussion at the next event. Any questions, comments?
One comment. Commonly, I could get something to my throat now. From a layman's point of view.
Yes, yes.
What I heard during your talk.
What am I doing myself?
What I heard during your talk is that dentistry is more preventative than curative, as I would put it, and that the dentist is more scientific in trying to save the patient's teeth than as was formerly, or your teeth is bad, let me extract it. Right? And it should be encouraging to these young folks who are getting involved into the profession to recognize the importance of doing constant research,
Yes.
so that they will be updated with what they're doing day by day.
You bring up a very salient point, and that's kind of the direction we're heading. And I think that's why we have legislation under Obamacare where now the provisions are expanded up until 26, and now, you know, these young patients are covered because we're trying to prevent tooth decay. We're trying to prevent tooth loss, and we understand that if we look at dental decay as a disease, which it actually is, that it's the most prevalent sort of disease that afflicts Americans compared to any other disease, right? Just think of all the kids. You guys remember Diamante Driver, young kid out of Maryland, I think, had an abscess tooth. His mom couldn't get him to a dentist. Went to his brain, whole nine, died, right? That's a major problem. We should never have any child die because they can't get care. Not to be too philosophical, but I feel that dental, I mean healthcare in general, but specifically oral health, is a right and not a privilege, right? We should all be afforded that opportunity. But with these sort of treatment options, we can be the best clinicians because we can provide our patients with a whole host of treatment options and really, you know, have some successful cases. So that's a great point there. That's my pops, by the way. Yeah. Official, unofficial pops. Yes.
So I know we looked at immature teeth today, but
Yeah.
have you seen any cases with mature teeth? Like in the case of external resorption, internal resorption using the same procedure to promote? Because if you use the term regeneration, then that's kind of, you know, speaking of the fact that it was already generated before, so to use it on immature teeth, you know what I'm saying?
No, I do.
Yeah.
I think that's an extremely good question. In terms of external resorption, these sort of cases, usually these are going to be on mature teeth. We understand that once the tooth is mature, those stem cells are not going to be as viable. So we really don't have any cases, at least not to my knowledge, but you encouraged me to go look a little bit further and actually see if there are any cases that have been submitted. But it's really because we understand that in the young patient, because of the resiliency of the tissues at that apical region, that these cases can be successful.
Good question. Thank you. Very well organized talk, so I appreciate it.
Oh.
Appreciate your time.
Thanks so much. Yeah, I feel like you guys want to do a good job.
So, quick question: like the polar opposites on pediatric dentistry and endodontics, is that I think we're both recognizing the pulp is a connective tissue, just like any other connective tissue in our body. But one of the things that I notice is different is that the American Academy of Endodontics will take like indirect pulp capping on an asymptomatic, hopefully normal tooth, and they do not advise that as recognized treatment option. Now on our side of the house, we have to see a lot of kids who don't have access to the endodontists that are going to see Medicaid, for which there's not many. So there's a huge need there. So if we preside this procedure, which evidence-based is telling us it's extremely reliable, and we look over at, I think he's in Sweden, Lars Borndal and his research. He's had a randomized control. So he's had an RCT come out saying that gives you, far superior success to any root canal if you select the appropriate case. So based on your endodontic colleagues, is there any movement to recognize this? Because right now it's not an ADA reimbursable code. We don't get paid for this. And I just think as a culture, as a profession, we need to move to recognize the light. And most endodontists, especially that don't appreciate the literature or the actual evidence, are going to say, we're not going to make money doing that. So why are we going to waste our time? But for us, when we see kids, it's the kids that can't afford it, and they can't, if I don't do that procedure, then I say you just need an endo. You'll never be able to follow up. So I guess that's my question: is do you know of any movement among your colleagues, the young endodontists out there, that we can kind of see eye to eye with?
I mean, that's a beautiful point. I can see that you have a good heart. You're really trying to treat the patient as opposed to just looking at it too. And I'm with you on that. I feel that if you can initiate any treatment that's going to be successful, meaning that the tooth is going to be retained, the patient's going to be asymptomatic, why not? Mm-hmm. The thing is to get it to be recognized collectively, by your association, what have you. I'm not too familiar with the pedodontic literature or how you guys all come together and support one another, but as endodontists, we lobby extremely hard for what we believe, and we have a very stringent board criteria to become board certified. So that kind of allows us to have a lot of autonomy in kind of dictating what treatments we accept and what treatments we don't. Okay. I don't know how it is for you guys, but I guarantee there are a lot of endodontists, not just young as me or as old as me, but just in general, that are of the same opinion. And we just want to get out there and help and treat these kids, because you're right. If a child needs treatment and they're under Medicaid, there's not too many people are Medicare. Not too many endodontists that I know that are actually going to get out there and do the work. But that's what was so important about having this discussion, because we wanted to say there's got to be some sort of nexus where we can come together. You guys are phenomenal at working with kids who have such, it's fearful for me. I hate seeing kids in my chair. I love kids. I have beautiful nephews and everything. I'm like, man, another kid? I get mad at the front desk like, I told you guys, why are you putting these in my schedule? It's seriously, I really cannot stand it, because it's such a challenge for me just to change my mindset. But you guys are trained, it's nice to have that. And so if we can sort of work together to actually have these successful cases, I don't know, I think this is a good starting point. And I have a lot of like-minded colleagues like myself. So, maybe we can develop a little study club and, just have some further conversation, discussion, see where we can go from there.
Go play some tennis.
What you said?
That's all I can do.
Okay. You want to say anything good?
I just have one more question.
Yeah, anything.
When you get the canal, bleeding in the canal, when you do the procedure, already you said that handling MTA is difficult. How do you then place the MTA in the presence of blood in the canal?
Well, the MTA, remember, you're allowing the blood to flow up to the cervical, the CEJ. So you have direct vision, you just can place it right in there, pat it in there. It's not like you're pushing it all the way down the canal. So from that aspect, it's a lot more manageable. You can manipulate it that more effectively. You're just staying within the coronal third, essentially. I mean, from my experience, I don't know. If
So it's not really technically difficult. 'Cause when
I don't know. I can't speak for you.
I know MC is like you make it sound like, right?
Yeah, you want to mix it to like a consistency, nice kind of thick. You can mix it to different consistencies, but if you get what's the instrument called when you kind of scoop it up?
Right.
Huh?
Lavatory.
Something like that, yeah. And you just kind of just put it right in the coronal third. I think you'll be fine. Like when we usually say that's difficult to use, like when you're doing an apical. You guys do apicals at all? Retro fills, retro preps. That's a problem. You know, you're in this small confined space trying to pack that into the apex. But I think if you give it a shot, I think you'll find surprisingly it's not that complicated.
Do you need to get pre-authorization for any of these codes? As far as you know?
That's a really good question because I don't know. But it's not a bad idea. You don't want to start doing something you can't get reimbursed, but you're a sweetheart, so you do it just out of the generosity of your heart. Right? No need to get paid.
It comes back to you eventually.
Got that Justin Bieber money. I only say that because she's from Canada. That's why. I like Justin Bieber. That's my boy. All right, so I guess if there's any other questions, we can get some ribs and some drinks.
I really want to thank everyone for coming out. I really want to thank Dr. Lori for pushing the Marcus to have
Right.
a discussion.
It's been a long time coming.
And make it happen. And thank Dr. Carrie Cunningham for being such a wonderful host over here. And if there are any questions, did you leave your card or? You didn't bring
I
your
got a
card?
couple cards.
I have cards up front. I know how to get in touch with Dr. Johson. And
You said you see kids, Jay?
See you later. That's how I see them. No, but actually, Long Island, we do see a lot of kids, so I know it may not be easy for in the city. I'll be honest, I really don't want to see kids. I mean, I will. It's not a problem. Right, that's how we're having this conversation. That's exactly we're having a conversation.
But Dr. Johnson is very entrenched in organized dentistry. You head up Nassau County Dentist Committee.
Yeah, I do, and I'd like to extend the invitation to any and all of you. March 29th, we're having a blockbuster event. I'm the new dentist chair committee, committee chair.
Yeah.
Committee chair. And it's going to be really nice because we're going to mix community service with some CE credits, and then everybody can enjoy the hockey game. I've never been to a hockey game out here, so the 29th of March. Okay. I can give you a flyer. You can disseminate the email. But yeah, everybody's welcome. Please come. We'd be more than happy to help you. I love organized dentistry because we have to have a voice. We're the future, and if we're not up on it and making changes and leading these changes, who else is going to do it for us? So I encourage all you to get involved. You don't have to be involved as me, but just at least show up to a meeting, see what's going on, and have a little say-so in the future, because the way healthcare is changing, the way the economy is, the way that the world is so competitive, and we're so interrelated, dentistry is changing, and you really have to be ready for those changes.